Thank you, and good afternoon, everyone. We've got a number of invited participants from coast to coast on today's call, and I'd like to thank everyone for joining today's webinar and inviting their colleagues with interest. For today's presentation, we'll be presenting results from a three-part quantitative and qualitative research program implemented in British Columbia. And I'm Chad Lever, Benefits Realization Leader at Canada Health Infoway. And our webinar today has two parts. First, I will share results from our patient survey and physician interview study completed in 2015. And this part of the webinar will be recorded, and the slide deck and webinar recording will be available on our website within the next week or so. Links to these findings from the publicly released patient survey and physician interview study will be sent, of course, to all registrants. The second part of today's webinar will be led by Dr. Kim McGrail from UBC. Kim will review results from a retrospective population-based quantitative study using comprehensive admin data on fee-for-service primary care in BC. These findings are, in fact, under embargo until publication this year, at which time we'll be publicly releasing those results. So as we heard from our coordinator, before we get started, just the housekeeping details. We are recording today. To support the recording, your phone lines are muted. At the end of the presentation, we'll be happy to take your questions, but throughout, please use the Q&A function on the webinar, send to all panelists, and indicate your question if it's specifically for myself or for Kim. Okay. On to the study. So for the purpose of this study, virtual visits are often considered as a domain of telehealth services, and this illustration here highlights the focus of our work, which was specific to the synchronous telehealth consultation in the highlighted area. A virtual visit is conducted between a patient and a provider using video conferencing, text, or telephone, and for this study we focused on patient-initiated virtual visits in BC. By way of background, virtual visits or synchronous telehealth services have had a formative history in Canada, yet in terms of patient-initiated consultations, these are only now becoming available to citizens more broadly. Indeed, the percentage of citizen or patient-initiated virtual care services in modern healthcare systems internationally is advancing. Where we see these are applied in the context of primary care, there are really two models of care where clinicians provide virtual visits to their own or attached patients, often on an invitation to participate basis, initiated by the physician, versus an opt-in basis initiated by the patient with their regular care provider or family clinic. In turn, virtual clinics, where clinicians provide care to new patients or patients they haven't seen before or unattached patients, is the second model of care. There are also multiple business models that support these models of care depending on local context. When we did the research being presented today, the context was fairly unique in that there was a mix of attached and unattached virtual visits occurring in BC, and at the time with the same functional capabilities aligned to the virtual care services available to practitioners, so things they could do with the patient online like prescribe and do lab requisitions, etc. And as such, our research situated in time was really quite perfect for a natural experiment. In order to fill important evidence gaps, Infoway, as many may know, regularly initiates primary research in partnership with academic scientists. We saw an important opportunity in the area of virtual visits in BC in 2015 where this activity had grown exponentially, particularly with the Medio service, which was made available to patients and physicians across the province around 2013. In order to, indeed, and as I said, in 2013-14, there were about 7,500 virtual visits billed to primary care physicians in BC. That's your graph on the left there. And on June 11th, 2014, Terry Lake, the Minister of Health for BC, announced a review of the telemedicine program, specifically with regard to the increased billings associated with virtual visits in the province at the time. Infoway was curious at the time what the system impact and value was for patients who access virtual visits, as well as the value to providers. So we collaboratively engaged with the BC Ministry of Health and Kim McGrail at UBC, CHESPR, on a proposed program of primary research in this area, and kept, of course, the ministry abreast of the findings, interim and final results accordingly. Specifically, the research program included 3 parts in partnership with Kim McGrail, who will present her results today. A population-based study was done, and the second study was the quantitative survey distributed to BC residents who had at least one virtual visit in the past year, and the patient survey aimed to look at general attitudes towards the value of virtual visit services in supporting their own health and the health of their families, the resolution of their primary health concern or the purpose of the visit, and the associated time and various value savings as a result of the visit. Our specific research questions are listed here on this slide, and they were really to understand the system impact and value of virtual visits for patients, as well as the value for providers. We developed a qualitative interview study for physicians. We did this in partnership with Medio or QHR Technologies, who supported defining the eligible sample set and disseminated the invitation to participate and reminder invitation to eligible patients for the patient survey, as well as to eligible physicians who are providing virtual care. Infoway engaged Harris Decima to administer the REB-approved consent process, the online patient survey, and conduct the physician interviews. All instruments were collaboratively developed and reviewed by the BC Ministry of Health, Medio, and Canada Health Infoway. The patient survey was in field between April and May of 2015, and patients took an average of 18 minutes to complete the survey. The data presented today is unweighted, and among the 3,025 patients registered to the Medio service who were eligible for the study, 399 completed the survey tool, and giving us a 13% response rate. This slide provides a comparison of the study sample to the full sample of patient subscribers to virtual visits and to the BC population. The results are based on those who responded to the survey and may not, in fact, be extrapolated to the larger population of users. But in summary, the majority of respondents were female, between 18 and 54 years of age, and were more likely to be married. There are, in fact, some fair comparisons to the subscriber population and to the general BC population on these aspects, but as you can see, subscribers do tend to be younger and are less likely to be male. With regard to other sample characteristics, most respondents report having a family physician or regular pace of care and have had one for about 9 years on average. Their doctors have good knowledge of their medical history, and 58% report having a chronic condition. 60% have had an in-person visit with a family physician in the last year, 40% have visited a specialist, 26% have visited the ER but were not admitted, and interestingly, 20% have accessed other virtual care services. Now for the patient survey results. This slide shows where patients who have had a virtual visit in the last 6 months first learned about virtual visits. The majority of respondents, as you see here, say that they first learned about using virtual visits from a friend or a family member at 51%, and 25% say they learned from a healthcare provider, whether it was their doctor, a nurse, or even a community service agency. In terms of their virtual visits over the past year, the majority of respondents report seeing a new provider or not their regular provider, with another 7% saying that they had virtual visits strictly with their regular provider, and an additional 7% seeing a mix of both regular and non-regular providers over the past year. The next few slides are on patient attitudes on the virtual visit experience, and the percentages on the right are the total of strongly and moderately agree, the orange and the blue areas of the graph. And as you can see, the virtual visit experience is really overwhelmingly positive for patients in terms of ease of use, to access to care, saving time, confidence in the privacy and the quality of the visit, and that the visit itself is of high quality. From the top of this graph, about 8 in 10 patients report that the experience is excellent or very good in terms of meeting their healthcare issue or need at the time. Their information is treated with the privacy and security that they expect. The aspects of the visit in terms of the physician-patient interaction and the ability of the physician to ask questions and understand or see physical symptoms is also rated highly, and the information received and the confidence in the physician themselves providing the care and the quality of technology is also fairly highly rated. And lastly, nearly about 8 in 10 report that their most recent online visit was as thorough as an in-person visit, with a fair proportion at 57% even saying that the physician knew their most recent medical history, and 45% saying that the doctor had access to their recent lab results. Given the high proportion of visits, as I noted earlier, with doing a virtual visit with a new provider, this suggests that the consultation is actually supported by key aspects of the physician-patient interaction, the consultation interview, and it's likely that physicians conducting care in this space are also using British Columbia's provincial lab service to identify important patient information when doing the consultation. A fair proportion, however, of patients report that that their physician they didn't know if this was the case, that their physician knew this. It may be that the physician did it, but the patients weren't aware, or and they say that there may have been limitations to the visit because of a physical exam could not be performed. A third of respondents believed that there were no limitations, and perhaps this variance is due to the different presenting conditions patients are using the system for, which may not require a physical exam from their perspective. At any rate, these metrics really indicate that there's more to explore in terms of the value for patients and the physician-patient interaction with regard to the service. In terms of comparison to traditional in-person visits, approximately 8 in 10 say the quality of the visit is really the same as the in-person visit, and even though 51% say it's better, 37% believe the virtual visit is really not better than an in-person visit, suggesting it's really complementary to the relationship of seeing a physician in person. With regard to the outcome of the virtual visit, 73% of patients received a prescription renewal or a new prescription, and when you bundle some of the categories on the left there together, basically about 30% got information that helped them reduce anxiety or got access to some online resources. 33% got a lab or a referral, which essentially is advancing their healthcare journey, and 18% got advice to contact a healthcare provider. Indeed, only 2% of whom was the physician triage considered emergent, so in other words, that the patient should go to call 911 or visit the emergency department. Essentially, patients who had a virtual visit found the online visit really helped them with their health care issue at the time, 91%. 79% say it was very helpful, and 12% say it was somewhat helpful. And when asked what patients would have done if they had not been able to see a doctor online, 48% say they would have gone to a walk-in clinic, 20% would have visited their own regular doctor or place of care, and 11% would have say they would have gone to the emergency department. 13% report that they would actually have not sought care at that time. In terms of motivations or the main reason for the virtual visit, regardless of the healthcare issue at the time, patients report that the main reason was really to save time and effort, and it's easy to actually book an appointment. Really only a small proportion say that getting a prescription was the main reason for the visit, despite the fact that that was the outcome for most patients using the service. And in terms of patient value, 57% of patients report that because of their most recent visit, they avoided an in-person visit. And those that did, pretty much everyone, at 98%, saved travel time at an average of $19, and the majority also avoided a work absence, and 39% saved time arranging childcare or caregiving services at an average of $33. And finally, the physician interviews were conducted with 23 primary care physicians who provided a virtual visit in the last year, and the majority were physicians who operate a general family practice with no subspecialty, and then there was a mix of age and gender and years in practice among our participating clinicians. The majority of physicians who participated in the interviews report that they conduct less than 5% of their overall monthly volume of patient visits virtually, and so essentially very few have incorporated virtual visits into their full scope of practice and are providing care mostly to new patients among those who were interviewed. As you see here, the main themes of the qualitative interviews included virtual visits as being complementary from a physician perspective to primary care practice, but not a replacement for in-person visits as the core relationship between the physician and the patient. Physicians say that virtual visits are comparable, really, in encounter time to in-person visits, with, yes, some limitations in assessment and physical assessment, yet there are important capacities that are outlined in our full report, which will be coming soon, that support patient engagement and patient education at the fore, and ongoing monitoring of patients and value for patients who may be seniors or in the home and travel may be a challenge for regular appointments. Essentially, physicians are saying the future of e-visits or virtual visits is a growth, both among patients and physicians providing this service. With that, I want to thank you for your attention on the patient survey and physician interview results. That concludes our review of this part of the study. With that, I would like to introduce Kim McGrail from UBC to discuss the results of her work as part of this program of research.
Thanks, Chad. Okay, so as Chad said, what I'm going to be concentrating on in this presentation is work we did using the administrative data available through the BC Ministry of Health. So this is very much a quantitative analysis based on the variables and information that we can find in those administrative data. You can go to the next slide for me. So just a review of what Chad already showed in this kind of form and function of telehealth or telemedicine. There's lots of ways to think about these different technologies and lots of different ways that they can help improve care in the healthcare system, including telehealth services that allow more physician-to-physician interaction as well as physician and patient interaction. So if you kind of go through this whole flow sheet, what we're, as Chad said, what we're concentrating on are the synchronous visits, so that when a physician and patient are interacting at the same time, and specifically the virtual visits, meaning the ones that are conducted using the video technology, so not telephone or text or any other kinds of things. And we're able to do this in BC because there are some specific fee items in the publicly funded healthcare system fee schedule that allow us to capture this information and to know that what actually was provided was a video visit and not a regular in-office visit. So what do we know in general about the effects of telehealth or virtual visits? And I use telehealth here because a lot of the literature, of course, doesn't necessarily relate specifically to virtual visits, but telehealth more generally. But I think from the existing literature, what we can say is that at least these kinds of visits can potentially reduce the effects of geography on distribution or access to care, because we know that in British Columbia, like many other or all other Canadian provinces, there are very rural and remote areas that do have less supply of physicians, including general practitioners, than other areas. Another thing that these sorts of visits could do is essentially extend the office hour availability if physicians choose to provide care outside of what we'd call normal regular office hours. Because they are virtual and some of the technology that was employed in BC enables patients to use their smartphone to have these visits, it can reduce time costs. Patients can have these visits where and when they are and where and when they need them. They do tend to be used for more minor conditions, and as you'd guess, based on the technology, it's conditions that really don't necessarily need a hands-on diagnostic approach to see what is going on. And in the U.S. literature, and I think reflected in what Chad showed in his results already, we do see that prescribing and prescription renewal specifically is often a very common approach. But if you combine those minor condition and prescribing, some of what we see in the U.S. literature is antibiotics for upper respiratory infections and some dermatological kinds of conditions being quite common. There's little information in the existing literature on longer-term effects of the use of these services, particularly on patterns of other healthcare interactions that we can observe. And that is an advantage of using the data that we're using here, is that we can actually say something about how these visits fit in an overall pattern of care. Next slide. You've seen this already. This is just to anchor that we were looking at 2012-13 and 2013-14, this period of time when these visits were increasing quite rapidly. The Medeo technology became available in October of 2012, which is why you see that increase really starting in that year and then ratcheting up quite quickly in 2013-14. Unfortunately, we were not able to extend to 2014-15 just when we started the study. That year of data were not available. It would be nice to be able to add those numbers in, but it wasn't possible here. So the research questions that we focused on in this part of the study were, are these virtual visit services substitutes for or complements to existing patterns of primary health care? So are these, when somebody goes and makes a virtual visit, is it replacing an office visit, or does it just seem to be an add-on service? And the other question is, what are the demographic characteristics of patients who are using these visits and clinicians who are providing the service in BC? We used administrative data on physician payments and pharmaceutical use, which in British Columbia we're fortunate to have all pharmaceuticals in our data systems, not just those that are paid for through the public system. We also have demographic information, age and sex and health status for patients, and age and sex for physicians, and location for both of them. We included all patients in this because we wanted to compare the people who are using virtual visits and not, and same for primary care physicians because we wanted to compare. This is really very much a population-based cohort. And for a sub-piece of the analysis, we used time series analysis and matching, where we wanted to look at that question about effects on other patterns of care in the system. And then we used the years 2010-11 to 13-14 so that we had some period of observation prior to when the virtual visits became available, and then as much as we could after the first visit to look at that ongoing pattern of care. We go on to the next one. So first question, who uses virtual visits in BC? So this is the patient perspective, and what you see across the bottom of this graph are the different demographic types of characteristics we looked at. And I'll emphasize that the percent really is a percent. I have not misplaced the decimal point here. So what we can say overall is a fairly low proportion of the population are using these services at all, well under 1%. And that shouldn't be a surprise given that we have really still under 10,000 total virtual visits we're looking at here. And so we really wouldn't make too much of the difference between males and females. It's about the same on that scale. Certainly the 20 to 44 age group is the highest user and in terms of proportions. And in the north, our northern province is also the highest user from the population perspective. So from thinking about the influence of these visits on addressing geographic distribution of care concerns, that's encouraging perhaps, but it's interesting to note as well that Fraser and Vancouver Coastal are the next two highest in terms of proportion of patients who are using these, and those are really BC's two most urban or most densely populated health authorities. So it's not entirely clear that this geographic thing is playing out exactly as we might have predicted. The next orange bars are about the socioeconomic status of patients. This is the best we can do. It's a neighborhood-based measure, not an individual-based measure of SES, and it's really based on income adjusted for household size. You see there's really no pattern there across income quintile. And then the last set of bars is health status. So we're measuring health status using the Johns Hopkins ACG system, which accumulates diagnoses over an entire year and then classifies people. And we just use a scale of how many serious conditions do people have. And what you see here is that there's generally an increase. So people who have multiple conditions that are expected to use more health care services are, in fact, more likely to use these virtual visits than others. Okay. So then we wanted to look at the reasons for people going for these visits. This is based on the ICD code that's present in the physician billing record. And we compared this to regular visits. So this is our matched control group of people who were not using virtual visits at all. So this is a regular in-office visit. And you can see, if you look at the percentage differences here, you can see that there's a bit more of use of virtual visits. It's more likely to be for some sort of mental health-related condition, and much more in the realm of the supplementary factors influencing health status. For those who know the ICD, this is ICD-9 coding that we still use in physician care in BC. These are the V code kinds of areas. So this is not it's not a disease or a specific injury or condition, but other reasons that people are seeking care. So it can be for follow-up care, it can be seeking advice, that sort of thing. Again, consistent with what you heard from Chad. I think we can go on to the next one. So who are the physicians billing and not billing virtual visits? Again, this is a relatively low proportion of all primary care practitioners are taking part in this. It's just like less than 3% overall, and again, absolutely no difference by male and female physician. But here, as with the patients, it is the younger physicians who are taking up these services more. And then we have this additional variable we looked at, and this is based on prior research, and I won't go into the details. I'm happy to provide any information people might like. But what we tried to do is look at an overall approach to care for each physician and then categorize them based on whether they seem to accept responsibility for ongoing longitudinal patient care. So the people who are high responsibility are those who look like they are really operating in what BC refers to as full service family practice. They really are taking on patients in a longitudinal way. So what you see here is that if you are a low responsibility practice, which really is, you look like a walk-in type of provider, you're more likely to be using these virtual visits. I can go to the next one. So another thing we looked at was when the virtual visits are provided, because if we were thinking about these being able to fill in gaps where regular primary care offices are closed, you might expect these things to be happening on Saturdays and Sundays. Unfortunately, we were not able to measure anything about the time of day, so we can't say anything about, 6 p.m. or 8 p.m. kinds of care, which may be happening. But from this chart, you can see that these services really are being provided on weekdays, not on weekends, and certainly not on Sundays. So then what happens at the visit or after the visit? And what we were looking at here is the prescription habits and referral to other practitioners, referral on to other laboratory or imaging types of tests. And again, we're contrasting the virtual visits and traditional regular office visit kinds of groups. And what you can see here is that they really are pretty similar, and the prescription line, I just want to emphasize that it really isn't a typo. It is actually exactly the same in both cases, so we're not seeing quite the same use of virtual visits or the relationship between virtual visits and prescribing that's been reported in the United States. The virtual visit group is less likely to be referred for a laboratory test and really much less likely to be referred for imaging, a little bit less for surgical specialists. But overall, quite a lot of similarity really between the two. And so then we wanted to assess this, is this a known provider or a new provider? And if we take the perspective of the virtual visit itself, half are with a known provider and half are with a new provider. If we take the perspective of patients, we find that about a third are seeing a known provider and 2/3 of patients are seeing a new provider. And the difference, of course, is that people can have multiple visits, and we've just included them all here. We go on to the next one then. So who's seeing a known provider? So here, again, no difference by sex, but interestingly, if you are older, which is red bars, and if you're sicker, which is the purple bars, you are more likely to be seeing a known provider. And in Fraser Health, one of our health authorities, that's the health authority that really sticks out as being a known provider. Interestingly, Fraser Health is the area of British Columbia where there is a small group of physicians who are working on non-fee-for-service payment practices. And we can't tell from our data whether it's those physicians who are the ones that are using this, but it's just an interesting kind of overlay of our understanding of patterns of care and approach to practice in British Columbia. You also can see from the orange bars, the socioeconomic quintile, that you are more likely to see somebody you know or that you've seen previously in a traditional office visit if you're higher income, and much less likely to if you are in the lowest income quintile. Let me go to the next. So then there's this question on this time series analysis of do virtual visits affect overall healthcare services use? And we looked at here, this is a contrast of patients with a traditional visit and patients with a virtual visit. And what you can see is they track reasonably well. They're pretty similar, and that's because we matched them in the pre-period. You'd hope that they'd be relatively similar. There's something that, of course, we're matching them, and time zero is the time of their visit, which is why there's an increase in the cost of GP services, because we're anchoring at zero at a point when we know that they had a visit. And then you can see afterwards it looks like perhaps the patients with a virtual visit kind of flat out in their healthcare services use, where patients with a traditional visit continue to increase. So there's some, I would say very cautiously, there is some preliminary suggestion that virtual visits may actually be beneficial to care overall, but I really don't think we should overinterpret this. This is relatively small numbers, and this really does deserve to have a better follow-up with a larger N and more follow-on time to the virtual visit to assess this. But it's an interesting signal that I think deserves some attention. So main messages from all of this, clearly the use of these services is growing rapidly, and it's been particularly pronounced in British Columbia in primary care because of this, this interesting intersection of an existing fee item in the fee schedule that allowed for the billing of these things, the public funding of these visits, and the development of this technology in Medio, and the way that they developed the technology and implemented it so that it really did allow physicians who wanted to incorporate this with their regular patients could take advantage of that. So the virtual visits, they do offer increased and easier access for patients and more flexibility in work arrangements for physicians. We can see that the younger age group, the 20 to 44 age group, and people who have at least one major condition, and those two things are not necessarily intersecting, but those are the groups that are more likely to use virtual visits. There's higher use in some very specific areas of the province, but really not a distinct geographic pattern in terms of rural versus urban and so on. There's probably just a lot of complex factors playing into that. Younger physicians, especially those under 35, are more likely to provide these visits, as are those who are running low responsibility or walk-in type practices. And then go to the next one. And just over a third of patients have a virtual visit with somebody that they know from a regular office setting. And that is increases with age and with complexity of their medical condition, which is probably an encouraging and positive finding. Those in the lowest socioeconomic group by neighborhood characteristics, though, are least likely to see their known provider, which is perhaps less encouraging. The time series analysis does suggest that there's something interesting going on here, but that really does need follow-up. So overall, I'd say there's not really a simple conclusion about the effect of virtual visits on existing patterns of health system use. It's partly because of the timing of our study and what we were able to do with the data available. But I think it's also probably that would be true under any circumstance because they're being used in quite different ways with quite different patient populations by different physicians. So really teasing apart this, it's really quite important to understand who's using them in with what patient populations to understand what effect that they're having overall. I will say that it's pretty clear from all of the evidence, and including, I think, a little bit of what we've seen here, that it is one means by which the health system can be more patient-centered. But I think that if we line that up with provincial policy and our overall objectives for the system, that really would be more pronounced in the area where patients are able to see somebody with whom they already have some kind of relationship. And I think that's the last slide, but let's just check and see. Oh yeah, so this is so there's just some supplementary slides. That was the last that I want to say. Here we can end. Here is this is the list of the fee items that we used and the dollar values attached to it, to all of it, and that is where I'll stop.
Great. Thank you so much, Kim. That was really, really excellent. I would like to invite those who are on the call to use the Q&A function for any questions. I haven't seen any pop up yet, but I do have one for Kim, mainly around the methodology that you took for addressing the research question or questions, and if you had any key lessons from the approach that was taken and how that could be applied to, say, other emerging models of care. Did you have like, oh, you know what, if we did this again, we would need this data element to explore further? Did you have any key lessons from the methodology?
Well, that's an interesting question. I think what we know from conducting this study is that the matching or some way of trying to make equal as much as possible the people who are using the services and the people who are not is really, really important, but very tricky, because we always know that, or we think we know that people who might engage in these technologies are probably different in some unmeasurable way than people who do not. So some attention to that would be useful. I think if we could really push this, it would be to try to compare what's happening with the different forms of implementation. So we didn't even touch some of the telehealth that's going on in BC. So for example, there's another flavor of telehealth where there's a nurse present with a patient who has to go to a specific site, and so the nurse can do hands-on things, and then there's a telehealth, a virtual visit connection with a physician who's remote. So trying to understand the different ways these are implemented, whether they're embedded in EMRs, what functions that physicians have, and how that affects the overall care and the impact on other healthcare services use. So more information about precisely what technology is embedded and how people are using it, I think, would be the one key thing I would want to add.
Excellent. Thanks. I do have a question. The question is, are physicians using virtual care primary care physicians, or are some specialists using virtual care? I think I can take that. I do know that among the physician providers in BC, and certainly in various areas across the country, specialists do conduct virtual consultations with patients, and as Kim mentioned, many of those are often supported with a nurse in various stations where the patient typically has to travel to. I don't, although Medeo does provide the service and some specialists and allied health professionals are there, I'm not 100% sure if they are patient-initiated. I would say it's probably, given the numbers Kim shows, an extremely small percent, if any, patient-initiated specialist consultations, unless they may be already in the care of a specialist who, there's ongoing consultation for, chronic disease management, where the patient is, from their home in some instances, actually consulting with a specialist for direct care and for ongoing management. But essentially, in terms of patient-initiated ones, I don't believe that those are actually in play. I don't see any other questions having come in, so thank you for that one. Maybe just one more question about where are we going, our next steps. We're planning on pulling both of these pieces into a manuscript for publication in late 2016, and I invite those on the call who may be interested in pieces of this work to contact myself directly if they see it of value. Doing the presentation again for some colleagues. We're open to doing that in advance of the publication, either myself or Kim, and would be happy to answer any questions through email or a direct call if you'd like to get in touch.
Hi, Ted. Sorry, I just wanted to interrupt you. I believe that there are a few questions on the Q&A if you wanted to take a look in that section.
Oh, pardon me. I'm sorry
no
about
worries.
That's great. Thank you. Sorry about that. Okay. Okay. I understand this. Does this support the exchange of documentation, both directions? If so, how is this being done? Secure messaging or prescriptions? To answer that question, it is a virtual consultation with video, so there is no secure messaging between patient and the physician. It's unknown to what degree the consultation information is actually sent to patients who are seeing a non-regular provider, and whether the consultation information is going to that provider. I think that would be determined within the consultation with the patient if the patient discloses they have a regular provider at the time. Next question is Medeo the harmonized solution being recommended by BCMOH? I don't know, unfortunately, the answer to that question. That's probably a question best answered by Medeo if they would, they have a public relations person. I'm sure you could reach out to them. Next question, would we be able to have a copy of the PowerPoints used in this presentation? Absolutely, the front half. The patient survey slides will be available in the next week or so as we publicly release those. They'll be available on the website with the first half of this recording. The PowerPoints for Kim's version, of course, are under embargo until scientific publication, but we are happy to talk about those if you would like to contact us directly in advance of that publication. Okay, the total number of respondents, what were they for the patient survey? In total, there was 399 respondents to the patient survey. Are there follow-up surveys planned, and what are some of the new questions that may be considered? At the present time, we don't have a follow-up survey planned for a virtual visit study in the future. I think we'd like to see where we go with this particular work, and as other pockets actually emerge, like in Ontario, there have been some, we may do that. I think we would revisit our patient survey and look more to value for patients, and as Kim said, look more into the technology and the functions that would be important to consider for both the provider side and the patient side. Another question, are there other video conference applications in use in BC? Yes, there is. There's Live Care, which is available in a number of locations. And how many docs does Medio have? And I think at the time when we were scoping out the feasibility of the study, there was approximately 150 registered physicians with Medio. Not all have been actively practicing virtual visits at the time, to my understanding. And for our study, we looked at physicians who had completed a virtual visit in the last year, and that was, I believe, around 50 to 75 who had done so. Is the recorded presentation available? Yes, it will be. As I said before, the front half of the presentation will be available. In BC, is there a requirement to have a provider, a nurse practitioner, or general practitioner on both ends of the telehealth session? That answer would be no, because a number of these visits occur with strictly the patient and the provider. So yes, the patient can just initiate the session when it's through the module such as the Medio model or I believe the Live Care model that is currently in function in BC. How does the virtual visits compare with other provinces? To my understanding, there is, other than a new instance in Ontario, no other provinces really have a virtual visit solution available for patients to initiate their own consultation. However, many provinces do have virtual visits occurring with special patient populations where there are providers supporting the initiation of the consultation with patients, such as a nurse in, say, a remote setting. How are the patients getting the prescriptions? Excellent question. So in the virtual consultation, the physician can issue the prescription to the patient and actually sends the prescription via autofax from the solution they're using within the Medio tool to the patient's pharmacy of choice. So essentially the patient goes to the pharmacy that they tell the physician that they'll pick it up at, and that's where the prescription is for them. And maybe this one's for Kim. Is there any data to suggest what is being prescribed re-pharmaceuticals medications?
So we have not yet looked at what is being prescribed. The one thing that we did a little more digging into is renewals versus new prescriptions, and we're still finishing that up, but it doesn't seem to be very different than the overall prescription level. But it's a good question of, I assume that the interest might be, is this about antibiotics and that sort of thing, but we haven't looked into that.
Mm-hmm. Great. Just some other questions. Was the service not available on the weekends? I believe the service is available 24/7. It's really a matter, do physicians position themselves for, for visits at that time. So I think, the service is up and running, but if a physician hasn't logged in and, either told their regular patient, I'm available to see you on this time, or has an open block to be able to take patients at that time, then there would be no visits available for patients to book. I think I just have thankfully, a little correction from one of our previous questions, just that Medio does have secure messaging between patients and providers, and Medio also has a file sharing to exchange information between providers and patients. So there is ample information sharing as well. The question here is, how do they maintain the legal record of care? I believe physicians actually use an EMR in the consultations and maintain that record. And finally, I'll just read this question. This would be a great initiative if access to physicians was cross-national. Those in Newfoundland could access physicians in BC in the evening, and those in BC who needed early morning consultation could find physicians in Newfoundland. Indeed, an excellent innovation idea, and would look forward to seeing that being implemented potentially. I think we often hear of Canada's limitations with geography, but I think in this particular instance it would actually be an asset for advancing care and access from coast to coast. And is there any follow-up work scheduled for years 14, 16, and 17? I think from our particular perspective, I hadn't planned on doing anything myself, but I don't know about you, Kim, if you see another body of research here emerging.
I do. I think part of the research that will have to emerge is I guess, a little bit of what I hinted to before, which is that while we were working in a situation where there was one dominant provider and one or two kind of dominant forms of telehealth, it's just all over the place now. So just even getting a handle on how people are using the technology and where the technology may be going in the next while, I think will be an important area. So not even a quantitative, more of a qualitative kind of assessment of that.
Mm-hmm. Okay, I think we're at the end of our stream of questions, and I'm sorry for missing those off the start. I think we have had great questions and discussion. I'm glad. Thanks, Caitlin, for popping in and catching me on that. So if there's nothing further, I want to give folks back a few minutes of their day. I want to thank Kim for your time and all your efforts on this great piece of really important and new work in the Canadian context. And I just have a few more questions pop in. What specific areas of mental health were utilized? Again, I guess I wouldn't really know the specifics of that. And Kim, I don't think that would be delineated from your specific codes, would it?
No, not anything more than an ICD can tell you. So there was a fair number of general depression symptoms and a fair number of anxiety kinds of things. Again, I think that's quite consistent with what Chad was able to say from the patient survey. But because we're reliant on ICD-9 coding, it's really not clear.
Okay, and I just have one more question, and then I'll say thank you and sign off, was around how did BC navigate the actual payment schedule for virtual visits, and if there's an opportunity for collaboration and leadership for other provinces. I think, and Kim, you can verify for me, this code happened to be there, so the code was in place and made it in a priori, which made it actually amenable to, uptake of virtual visits. Is that about right?
Yeah, that is correct. It was the code preceded the technology, not the other way around.
Mm-hmm. And therefore, the uptake. And I think there is opportunity for collaboration and leadership as we, present and publish these results and potentially define, opportunities or policies in the way forward through that work and in collaboration with other partners across Canada. So with that, again, I want to thank Kim and everyone for their time on the call. Please reach out to us directly if you have additional questions and reflection of this work. Thank you and enjoy your day.